So, surgery in the pregnant patient. So, surgery in the pregnant patient. So, first we will see about the physiology and the basic concepts. So, the presentation of surgical disease in the pregnant patient may be atypical or mimic signs and symptoms of a normal pregnancy. So, that is one problem because the disease will not have any separate signs or symptoms. It will be just like pregnancy. So, next, very important is physiological changes during pregnancy. What is concerned for us? So, first about the diaphragm. Diaphragm can be elevated in pregnancy up to 4 centimeters above the normal level, and the lower chest wall can widen up to 7 centimeters square. So, next is most of the changes are due to elevated progesterone and estrogen. So, elevated progesterone level as well as decreased serum motilin results in smooth muscle relaxation. So, that is an important point. Motilin is decreased, progesterone and estrogen is increased. So, because of decreased motilin, smooth muscle relaxation happens. So, because of this, there is diminished gastric tone and gastric motility, increase in incidence of GERD. So, because even the esophageal sphincter tone will be reduced. So, reduced tone, there will be increased GERD. So, increase in small bowel transit time, all it is explained because of the motilin, decrease in motilin. But the important point is, they can ask this as a true or false statement. Because the motility has decreased, will the absorption decrease? No, absorption will remain unchanged. In fact, iron absorption will be increased because of the high demand of iron in pregnancy. So this may come as a true or false statement. Though the transit time is reduced, the absorption will be normal. So next in the colon, pregnancy-related changes usually manifest as constipation. This is caused by combination of increased colonic sodium and water absorption, decreased motility, and mechanical obstruction by gravid uterus. So these are the causes for constipation. So next is increase in portal venous pressure. So increase in portal venous pressure, there is an increase in pressure in the collateral venous circulation, and therefore it results in, just like cirrhosis of liver, it will result in dilation of the gastroesophageal junction veins, and also it occurs in the hemorrhoidal plexus. So there is also hemorrhoids. So among these two, which is more common? So common things are only common. So hemorrhoid is more common than the esophageal varices. So next is increased in gallbladder volume and gallstone formation. So the alteration in the function of gallbladder occurs. So the volume of gallbladder may be twice that found in the non-pregnant state, and up to 4% patients have gallstones on routine obstetric evaluation. So the risk of development of gallstone increases with multiparity. So that may come as a statement. Next, some of the changes of pregnancy closely resemble those of liver disease. So spider angioma, palmar erythema, elevated serum estrogen levels, hypoalbuminemia is also seen along with elevated serum cholesterol, alkaline phosphatase, and fibrinogen levels. Serum bilirubin and hepatic transaminase levels remain unchanged. So, which in the LFT, which is elevated? So, elevated is cholesterol, alkaline phosphatase, and fibrinogen. So, which remains unchanged? Bilirubin and transaminase, AST, ALT will remain unchanged. Albumin will decrease. So, that is the LFT. Next is coming to the cardiovascular system. So cardiac output increases as much as 50% during first trimester of pregnancy because blood has to also go to the fetus. So cardiac output will increase up to 50%. Next, during the third trimester, cardiac output is drastically decreased when the mother is lying supine. So what happens in third trimester? The uterus will become very much increased in size. So the gravid uterus, it will compress on the inferior vena cava, thereby reducing the venous return. And when the venous return decreases, obviously even the cardiac output will decrease. So with this drop in preload and an increase in sympathetic tone, there is an increase in sympathetic tone which maintains the peripheral vascular resistance. So sympathetic tone, like adrenaline, noradrenaline will increase the peripheral vascular resistance despite of the drop in preload. So another thing is supine hypotension syndrome. So what is supine hypotension syndrome? Just now we discussed, when the patient lies supine in the third trimester, there is drop in the blood pressure. So this is a problem in the anesthesia during third trimester. So during third trimester, the anesthetic agents, as we all know, if we put spinal, there will be decrease in the sympathetic tone. So already there is reduced pressure, which is compensated by sympathetic tone. When the anesthetics are given, again sympathetic tone will reduce more. So that is the problem with anesthetic agents in pregnancy. So what position should the gravid uterus, that is in the patient in the third trimester, what position should they adopt? So in case of trauma and all, they should be in the left side down lateral decubitus position. So left lateral decubitus with left side down. So this is the procedure for any trauma patient, any pregnant trauma patient, and any patient for any procedures which are performed in third trimester. So next, there is something called the inguinal varicosities. So they are inguinal swellings which is due to varicosities of the round ligament. So due to vessels in the round ligament, there is varicosities. So we don't have to do anything for these varicosities. They will resolve postpartum. So it has to be differentiated from femoral or inguinal hernia. So next is oxygen consumption. Coming to respiratory system. So oxygen consumption is increased during pregnancy. We all know that. Minute ventilation increases by 50% because of increase in tidal volume, which appears to be a result of elevated serum progesterone. So why the minute ventilation increases? It is not due to estrogen, it is due to progesterone. It can come as a true or false statement. So progesterone not only increases the sensitivity of the respiratory centers to carbon dioxide, but it also acts as a direct stimulant to the respiratory system. So next is coming to the partial pressure of oxygen, PaO2. PaO2 is also high. It ranges from 104 to 108. Normally it will be from 75 to 100, but here it is 104 to 108. So next is PaCO2. So what is normal PaCO2? Normal PaCO2 will be around 35 to 45, but in pregnancy it is reduced. It is from 27 to 32. So it is less than normal. So PaO2 is more than normal, PaCO2 is less than normal. So the decreased PaCO2 level increases the carbon dioxide gradient from the fetus to the mother. So this is what is happening. Because of decreased PaCO2, the gradient from in the fetus, there is more carbon dioxide. So the carbon dioxide from fetus goes to the mother and oxygenated blood from mother goes to the fetus. So next, another thing is oxygen hemoglobin dissociation curve of maternal blood is shifted to the right. So what happens if oxygen hemoglobin shifts to the right? Oxygen gets released. So oxygen will get released and it is delivered to the fetus. So shift to right, oxygen getting released. Next, elevation of the diaphragm. We saw before. It elevates 4 centimeters, resulting in decreased total lung volume by 5%. So because of 4 centimeter elevation, 5% lung volume is decreased. Next, diminished expiratory reserve volume and residual volume results in functional residual capacity that is 20% lower than that of the non-pregnant woman. So FRC, functional residual capacity, is also less than 20%. And only thing that remains unchanged is vital capacity and inspiratory reserve volume. So these two will remain unchanged. Next, coming to renal. So in the renal system, what will happen? So there is increased glomerular filtration by 50%. That accompanies a 75% increase in renal plasma blood flow, renal plasma blood flow. So because of increased GFR, there will be increased renal plasma flow. Then blood urea nitrogen level decreases by 25% during the first trimester. So BUN decreases by 25%. Next, serum creatinine. What happens to creatinine? Creatinine level also decreases by the end of first trimester from a non-pregnant value of 0.8 to 0.7 to as low as 0.5. So next is a 5 to 10 fold increase in serum renin levels occurs with a subsequent 4 to 5 fold increase in angiotensin. So renin, angiotensin, everything will also increase. So this is all for the benefit of the fetus. So one table shows this table. So this this table there is no MCQ. It's only statistics. This table only there is MCQ. So next is what about the osmolality? Osmolality decreases in the pregnant patient because of increased fluid accumulation and dilution. So it's 270 to 280. So normally it will be around 300. So it is from 270 to 280 in pregnant woman. So next is the blood parameters. So there is increase in WBC count during pregnancy. So how much it increases? So in first trimester, white blood cell count, the range is 3,000 to 15,000. And second and third trimester, it is 6,000 to 16,000. Next is platelet count progressively declines throughout pregnancy, whereas mean platelet volume tends to increase after 28 weeks. So pregnancy is a procoagulant state. So more of clotting will occur. So how the clotting? It is not because of the platelet count. It is because of the mean platelet volume. So volume of platelets will increase after 28 weeks of gestation, but platelet count will decrease throughout the pregnancy. So that is another confusing point. Just make note of it. Next, increased platelet count together with the high levels of circulating estrogen increases procoagulants, and progressive venous stasis generates a hypercoagulable state during normal pregnancy. Plasma fibrinogen, von Willebrand factor, factor 2, 5, 7, 8, 9, 10, and 12 increases. So all the clotting factors increases. Protein C and protein S. So what is the function of protein C and protein S? It will lyse the clot. So their levels will decrease. So there is no factor which lyses the clot, and all the clotting factors will increase. So it will lead to increased clotting. Then PAI, plasminogen activator inhibitor, and PAI 1 and 2, it will increase. So the inhibitors of plasminogen activator will increase. So what is the meaning of that? It means the plasminogen will not get activated. Plasminogen is needed for clot lysis. So same concept. So next, there is fivefold increased risk of venous thromboembolism in pregnancy. So despite all these alterations, the coagulation cascade, platelet count, bleeding and clotting times are unchanged. So all these will occur, but when we take the blood sample, it will be unchanged, but there is a fivefold increased risk of venous thromboembolism. So next is coming to the radiological concerns. So what is the acceptable maximum dose of ionizing radiation can be given in a pregnancy? So entire pregnancy, entire period of pregnancy, only 5 centigrade should be given. So the fetus is at highest risk of radiation exposure from the pre-implantation period to approximately 15 weeks gestation. So this is the point. So during this time, we will not know whether the patient is pregnant or not. So we should always be careful when a female of reproductive age group comes to us before we prescribe them CT or X-ray. So because fetus is having highest risk at the first trimester and even before implantation. So that is the important thing. So primary organogenesis occurs during this time, and teratogenic effects of radiation, particularly to developing CNS, are at the highest. So CNS will be problematic in development. Perinatal radiation exposure has also been associated with childhood leukemia and childhood malignancies. So congenital malformation is higher than 10 centigrade. So only up to 5 centigrade is allowed. If it goes more than 10 centigrade, it will lead to congenital malformations. So first and early second trimesters, when the risk of exposure is greatest. So first trimester and early second trimester, exposure is greatest. Then MRI in pregnancy. So this is one important, very interesting point, which I noticed only when reading this chapter. So we will all think MRI in pregnancy is safe. But according to the National Radiological Protection Board, they are advising against MRI in first trimester. So even MRI should not be done in first trimester. So we will all think there is no radiation, but we can do MRI. So what is the effect of MRI? The gradient magnetic fields may produce electrical currents in the patient, and high frequency currents induced by the radio frequency field may cause local generation of heat. So because of this heat generation, again in the chapter it will come, they say it will form cavity because of the heat. So this is a risk in the first trimester. So National Radiological Protection Board has advised against MRI during the first trimester. So this is very important point. If we don't read this chapter, we will miss this point. So here, highest risk. So examination type and estimated fetal radiation exposure in centigrade. So highest is which of these? It is barium enema. So barium enema is the highest, 3.9. Then after that only comes up CT abdomen. So barium enema is before CT abdomen. So that is one significant point in this table. We might miss it. We will think CT abdomen is highest, but barium enema is having the highest. So next is CT has been performed during pregnancy with iodine contrast, and neonatal thyroid function should be checked. If CT has been done during pregnancy, we have to check the thyroid function of the neonate. Then no effect on the fetus has been observed after the use of gadolinium contrast medium with MRI. So iodine contrast for CT, it is having an adverse effect, but gadolinium contrast for MRI, it has no adverse effect. So next, another thing is, just like CT, even ultrasound has tissue heating and cavitation. But for ultrasound, it is only theoretical effects. It is not practical, so ultrasound is safe. So certain disease process such as palpable breast mass or suspected appendicitis may be evaluated effectively and safely with ultrasound. So ultrasound only may be enough for these cases. Only if ultrasound cannot pick up the disease, we have to go for MRI. So next is medications. So in 1979, the FDA, US FDA, they had a 5-letter risk category. So A, B, C, D, and X. So this is called PLLR, Pregnancy and Lactation Labeling Rule. So PLLR is A, B, C, D, X. So we'll see one by one. So what is category A? So category A, these drugs have been tested and found to be safe during pregnancy. So they have been tested. There are studies which are saying that these drugs are safe. So category A includes folic acid, vitamin B6, thyroid medicines. So these are the drugs which come under category A. Next, category B. These drugs are frequently used during pregnancy. They do not appear to cause major birth defects or other problems. So there is not much study, but they do not appear to cause any defects. So category B are antibiotics, prednisone, insulin, acetaminophen, aspartamate, famotidine, ibuprofen. So pregnant women who should not take ibuprofen during the last 3 months of pregnancy, because ibuprofen will also be teratogenic, not teratogenic. In the last 3 months, it might induce this thing, because it's an NSAID, it might close the ductus arteriosus. So it will come later. So category C, more likely to cause problems. So from C, we have to avoid the drugs from category C onwards. So more likely to cause problems for mother or fetus, and drugs for which safety studies have not been finished. So study is going on, but it is not finished means it is category C. So what are category C drugs? So prochlorperazine, pseudoephedrine, fluconazole, ciprofloxacin. So these are some antibiotics, and one antifungal is there, and this thing, one antipsychotic, prochlorperazine. So category D, they have clear health risk. So clearly we know these drugs will cause problems. So alcohol, lithium, phentoin. So these are the drugs which cause defects, and it is in category D. Category X is, it has shown to cause birth defects. So there are proven studies that shows that these drugs will cause birth defects. So examples are isotretinoin, and for psoriasis, N-etretinate, acitretin, thalidomide, and DES, diethyl stilbestrol. So these are drugs which occur in category X. So what will diethyl stilbestrol cause? Any idea? Diethyl stilbestrol.
Vaginal carcinoma in infants.
Okay, yes. So that is important point. Next is analgesics. Analgesics. So first is over-the-counter medication. So over-the-counter medications, acetaminophen, the ingredient in Tylenol. So Tylenol is the company name. It occurs, it is safe during pregnancy, well researched by scientists. So acetaminophen, like our paracetamol, it is well researched. So we can give in any trimester. It can be given in all 3 trimesters. Para is safe in all 3 trimesters. So next is NSAIDs. NSAIDs like aspirin, ibuprofen, naproxen. So aspirin, which contains salicylic acid as active ingredient, should generally be avoided by expectant mothers because it can pose risk for mother and fetus. So aspirin is not recommended during pregnancy. Only low dose aspirin, that is 60 to 100 mg daily, is sometimes recommended for pregnant women with recurrent pregnancy loss, clotting disorders, and preeclampsia. So for clotting disorders, recurrent pregnancy loss, these patients we can give low dose aspirin. But as such, normal dose aspirin, it is not recommended. So next is during the first trimester, use of higher dose of aspirin poses a concern for pregnancy loss and congenital defects. So taking higher dose of aspirin during 3rd trimester has the risk of premature closure of the vessel in fetal. So what is that? It is nothing but ductus arteriosus. It will prematurely get closed. And bleeding will also occur in the brain of premature infants. Intracerebral, intraventricular hemorrhage, all that will occur. So ibuprofen and naproxen are safer options, but both should be used with caution. They are considered safe in the first 2 trimesters and are ill-advised in the final 3 months. So all NSAIDs we should avoid in the 3rd trimester because of risk of closure of PDA. So increased bleeding, that is all common. So next is prescription medication. So now we saw over the counter, next prescription. So prescription medications like all these hydrocodone, tramadol, acetaminophen, Vicodin, all those things. So they are used occasionally in pregnant patients when the benefit of the drug outweighs the potential risk. So no known safe levels of narcotic use during pregnancy. The risk to the fetus includes poor fetal growth, stillbirth, preterm delivery, and very low risk of birth defects. So preterm delivery, stillbirth, poor fetal growth, all those may occur because of the opioids, narcotic use. So next, antibiotics. So antibiotics first is aminoglycosides. So gentamicin, tobramycin, all those. So among the aminoglycosides, gentamicin, tobramycin, amikacin, they are determined to have low risk to the fetus and used commonly in pregnancy. But kanamycin, streptomycin, they are, we already know streptomycin will cause ototoxicity. So fetal auditory nerve damage and deafness. So kanamycin, streptomycin should not be used, but gentamicin, tobramycin, amikacin can be used. So next to toxicities, we all know it is nephrotoxicity. So nephrotoxicity will also occur. Fetal renal damage after maternal gentamicin treatment has not been documented. There have been cases of severe neonatal nephrotoxicity after therapy with this drug. So there is no documented cause, but they have seen a lot of nephrotoxicity after this thing, aminoglycosides, mainly gentamicin. So next is tetracycline. Tetracycline, we all know, just like for adults, it will cause depressed bone growth, and this thing, pigmentation and discoloration of the teeth. So doxycycline, tetracycline, minocycline, accumulation of drug occurs in developing teeth and long tubular bones. So because of the long tubular bones, it will cause depression of the bone growth. Then acute fatty metamorphosis of the liver in pregnancy following tetracycline will occur. So this is one specific side effect of tetracycline, acute fatty metamorphosis. So next is risk of dental staining, depression of bone growth, also pertain to doxycycline use during the second and third trimester. So doxycycline, so bone and teeth pigmentation, these are the two main things. And for specifically for tetracycline, there is acute fatty metamorphosis of liver. So next, metro. Metro we can use in the first trimester is contraindicated because of birth defects due to metronidazole. We can use in other trimesters. So in the first trimester, if the pregnant patient comes with the bacterial vaginosis or vaginal trichomoniasis, we should not use metro. So that is the important point, last line. So next is penicillin. Penicillins are like amoxicillin, vancomycin, nafcillin, penicillin G, penicillin V, piperacillin, all those. So no adverse fetal effects have been associated with this group of medications. So there is no adverse effects as such. But the common thing is anaphylaxis. If anaphylaxis due to penicillin occurs, it will result in compromised placental circulation. Fetal death also will occur, fetal damage or fetal death. However, in general, penicillin does not cause any teratogenic effect. So penicillin as such will not cause, but if the patient is allergic, if anaphylaxis occurs, it may also cause fetal death. So that is the point. So next is cephalosporins. So what they are telling is, out of the 5 generations, only first and second generation they have studied extensively in pregnant patients, and most of them are safe. But third, fourth, and fifth generation, because they are all recent drugs, there is not enough information. Studies are very less. So they are saying they don't know the effects of the third to fifth generation. Only first and second generations are safe. Next to clindamycin. So clindamycin also there is limited data, but they are saying it's a category B drug. So like amoxicillin, penicillin, and vancomycin, and effective treatment for bacterial vaginosis and abnormal vaginal flora. So we saw metro we should not give in the first trimester, but we can give this thing, clindamycin and all. So next is macrolides. Macrolides are safe anytime during pregnancy. So there is no any adverse effect. And next is sulfonamides. Sulfonamides is trimethoprim sulfamethoxazole, that is cotrimoxazole. That has caused neural tube defects, cardiovascular malformations, urinary tract defects, oral cleft, and clubfoot. So due to trimethoprim being a dihydrofolate reductase inhibitor, it is thought that folic acid supplementation can reduce the risk of congenital defects if they are administered prior to conception or concurrently with the antibiotic. So if we give folic acid along with the trimethoprim, then there might be less chance of defect. Other defects of cotrimoxazole are kernicterus, so it should be avoided. So main are all these neural tube defects, cardiovascular defects, urinary tract, clubfoot, cleft lip and all, and kernicterus. So next, fluoroquinolones, ciprofloxacin, moxifloxacin, all those. So pregnancy has not demonstrated any increased risk of congenital malformations, but many reports are there for birth defects. Ciprofloxacin does not have any teratogenic effect and is assumed safe for use in pregnancy. But animal studies have shown fetal cartilage damage, so we should avoid in the first trimester when all the cartilage will develop. So animal studies is only there is no human studies, but generally it is safe. So other gram-positive agents like vancomycin, clindamycin are used for multi-drug resistant gram-positive infection or for penicillin allergic patients. So for penicillin allergy, we can give clindamycin and vancomycin, and also for MDR gram-positive, multi-drug resistant gram-positive infections. So next is coming to anticoagulants, heparin. So heparin, there are 2 types. We all know, low molecular weight and unfractionated. So among these 2, which is safe in pregnancy? So it is low molecular weight heparin. So low molecular weight heparin is category B, unfractionated is category C. So neither of these agents cross the placenta and are safe in pregnancy. However, unfractionated may be associated with increased maternal bone loss. So it is low molecular weight is better, but both of these will not cross the placenta. So it might be confusing. We may think low molecular weight will cross the placenta, but no, even low molecular weight will not cross the placenta. So next is danaperoid. Danaperoid is a low molecular weight heparin with both anti-10A and anti-thrombin effects. So this is danaperoid. So it neither crosses the placenta nor is secreted in the breast milk. So danaperoid is safe for nursing mothers and for and for pregnancy. So that's what they're saying. Possibility of heparin-induced thrombocytopenia, but however, it remains the anticoagulant of choice for use in pregnancy when HIT has occurred. So heparin, danaparide will also cause heparin-induced thrombocytopenia, but if there is heparin-induced thrombocytopenia, we have to give danaparide. So next is coumadin, that is warfarin. So warfarin is contraindicated in pregnancy. We all know it is very dangerous. So it is category D, associated with miscarriage, prematurity, low birth weight, neurodevelopmental problems, fetal bleeding, risk of major birth defects with the first trimester exposure. So in select circumstances, warfarin has been used in pregnant patients. So what are those select circumstances? It is mechanical aortic valve targeting the lower INR of 1.5 to 2 without complication for the mother or fetus. However, this use of warfarin is still investigational. Postnatal period, however, warfarin is suitable alternative to parenteral anticoagulants such as heparin. So only in mechanical heart valves they can be used, but this is also under investigation. So it is not contraindicated in breastfeeding. So this is one confusing thing. Warfarin can be given in breastfeeding mothers. So factor 10A and direct thrombin inhibitors. So new oral factor 10A inhibitors. So all those rivaroxaban, apixaban, all those, these may cross the placenta. So in situations of severe reaction to heparin and danaparide, direct thrombin inhibitors can be used. Fondaparinux is the agent of choice. So what is the drug of choice for severe reaction to heparin and danaparide? It is fondaparinux. So it does not cross the placenta. Fondaparinux is FDA class B, but there is another category called Australian category. So in Australian category, it is category C. So only in this place they are mentioning about Australian category. Don't get confused. So fondaparinux is safe, category B drug. So direct thrombin inhibitors, hirudin, lepirudin, agatroban are not licensed. So next is aspirin. Aspirin we saw first result. It may cause teratogenicity and fetal toxicity, premature closure of ductus arteriosus. So it is category D. And dose we can use low dose aspirin like 60 to 100 mg. Indicating treatment is relatively safe at these levels. Either a mechanical prosthesis or bioprosthesis in second and third trimester. So those patients, they can receive low dose aspirin. So clopidogrel. Clopidogrel is category B. So clopidogrel, there is no evidence that clopidogrel increases placental abruption or other antepartum obstetric bleeding events. Additionally, thus far, there are no reports of fetal hemorrhage. Recommends to hold clopidogrel for several days prior to elective delivery or administration of epidural anesthesia. So there is bleeding risk. So if we are planning to give epidural, we have to delay it for 7 days. So next, thrombolytics. So there is only limited data. Important is for acute venous thrombosis what we are going to use, and for acute arterial thrombosis what we are going to use. So acute venous thrombosis like May-Turner syndrome, mechanical thrombolysis is recommended. For arterial, like stroke and all, we have to give recombinant TPA. So for venous it is mechanical, arterial it is TPA. Just remember stroke. Arterial is stroke, so we give recombinant TPA. So in general, intra-arterial TPA with or without combined mechanical is preferred to systemic TPA. So that is another thing. So by radiological intervention radiology, if we give TPA in the intra-arterial route, it is better than systemic route. So that is the only MCQ point. So next is diazepam. Diazepam, it has increased frequency of cleft lip and cleft palate, but does not show first trimester usage to be teratogenic. So there are some studies which say it does not show any effect, but it has proven to cause cleft lip and cleft palate. So midazolam is unsafe. It is category D. So it can cause birth defects and other problems, midazolam. So next is anesthesia concerns. So there are two types of concern. One is direct concern, another is indirect concern. So changes in uterine blood flow and maternal acid-base status may cause hypoxemia or asphyxia in the fetus. So placental passage of anesthetic agents that affects the fetal central nervous system or cardiovascular system. So direct effects means they relate to the possible teratogenic or embryological properties of the drug. So indirect effect is by any physiological mechanism, not directly because of the drug. So most common effects are indirect. So next is the most profound effects on the fetus are related to decreased uterine blood flow or decreased oxygen content of uterine blood. So just now we saw that is the indirect effect. Uterine circulation is not auto-regulated. So if there is any insult like brain, it cannot increase the blood flow to the uterus. So during third trimester, 10% of cardiac output goes to the uterus. So phenylephrine, metaraminol are alpha agonists that are effective in maintaining maternal blood pressure and preventing fetal acidosis. So metaraminol, phenylephrine will prevent fetal acidosis by maintaining BP and maintaining the steady blood flow to the fetus. So for a congenital defect to result, exposure to a teratogen must occur during the vulnerable differentiation age of the affected organ system. So what is the vulnerable age? It is, we saw earlier, it is the first trimester and the early second trimester. So large survey studies have demonstrated an increased risk of spontaneous abortion, intrauterine growth retardation, low birth weight neonates in women who require surgery during pregnancy. So any surgery, like for example, if we are doing appendectomy, then that pregnancy will have high risk of spontaneous abortion, IUGR, and low birth weight. So these are the three things. So fetal surgery during second and third trimester has not been demonstrated to have adverse effects on fetal neurodevelopment. So another one named trial is there, Panda Trial. So Panda Trial is a trial which failed to demonstrate significant long-term adverse effects from single anesthetic before 36 months of age in matched sibling pairs. So long-term adverse effects were not being reported if it is used before 36 months of age. So that is Panda Trial. They have not elaborated, they only told the name. So elective surgical procedures are delayed until at least 6 weeks after delivery. So if elective surgery has to be done on the mother, we have to delay until 6 weeks. Then only the maternal physiology will return to the normal non-pregnant state. But when emergency surgery is required, the life of the mother only takes priority over the fetus. So that is one this point, legal point. So semi-elective surgical procedures, attempts are made to delay surgery until after first trimester. So elective surgery, we have to delay 6 weeks after delivery. Emergency, we can do, and if emergency is done, mother's life is more important. If it is semi-elective, then we have to delay until the first trimester is over. So second trimester is the window period. So we can do, second trimester is the safest period to do surgery. So there is almost no risk for anesthesia-induced malformation or spontaneous abortion. So later in pregnancy, during third trimester, the risk of preterm delivery is highest. So what is the problem in first trimester? Teratogenicity of drugs. The problem in third trimester is preterm delivery and abortion. So only second trimester, there is no risk of any of these. So next is continuous intraoperative monitoring has to be done if we are doing any surgery. So what is the monitoring is, we have to do transvaginal ultrasound. So transvaginal ultrasound, we can check the placenta and also this thing of the fetus. So if any there's any signs of any preterm labor, then we can immediately manage it properly. So another important monitoring is fetal heart rate and uterine activity. Tokometer has to be done. Why we are doing this tokometry? To check for any premature contractions and to prevent preterm labor. So even if intraoperative monitoring is not believed necessary or unavailable, we have to do this fetal heart rate and tokometry, or at least these two we should do. So for pain, NSAIDs are not used. So we know obviously it will close the ductus arteriosus. IV acetaminophen, morphine, fentanyl are good choices post-operatively when oral analgesics are insufficient. So orally, if they are not enough, we have to give IV para, IV morphine, all those. Patient control analgesia pumps after surgery may be best choice. So oral narcotic use is generally considered safe in pregnancy. So what are the safe narcotics? Oxycodone, hydrocodone, and codeine, and can be safely used in moderation. But chronic use, what is the problem is fetus will develop dependency because of the narcotics. So prevention of preterm labor. So what we can do to prevent preterm labor during surgery? So preterm labor incidence is associated with the gestational age and the indication for surgery. If it is a emergency surgery, there is more preterm labor chances. And if there is a high gestation age, high gestation age will also have more preterm labor. So preterm labor induced by non-obstetric surgical intervention is 3.5%. So the later in gestation is the patient, highest is the risk of preterm contraction and preterm labor. Intraperitoneal surgeries and disease process with intraperitoneal inflammation, like for example appendix, is most likely to have post-operative course complicated by preterm contractions, because we are going into the peritoneum, uterus might get irritated. So delay in the treatment appears to increase the chance of preterm labor, likely related to the primary disease process. So laparoscopic and open techniques have equal associated incidence of preterm labor. So we will think lap has less, but no, lap and open both have same incidence of preterm labor. So tocolytics, if we use tocolytics, can we prevent preterm labor? So that is also one of the important concepts. So tocolytics can only be used if contractions are noted during post-operative monitoring or are appreciated by the patient. So tocolytics we cannot use as a prophylactic agent. Only if there is contractions and if the patient is experiencing contractions, we can give tocolytics. So preventing preterm labor and preterm delivery, when post-operative contractions are detected, tocolytics can be used successfully. So what can be used? Terbutaline, magnesium, and indomethacin. All these can be used. So before 32 weeks, we can give indomethacin, and if it is more than 32 weeks, we can give terbutaline. So what is the reason for this? Before only we have to give indomethacin before 32 weeks. It's a repeated concept in this chapter.
Ductus arterius.
Yes, very good. So it will close the ductus artery. So before 32 means we have to give indomethacin. After 32, terbutaline. So abdominal pain and acute abdomen. So this is a tabular column. So here we have all the causes. So one important thing in this table is acute appendicitis. We can see acute appendicitis in right upper quadrant pain also. Right lower quadrant, obviously we will know. Flank also. Even if there is flank pain, it can be acute appendicitis due to retrocecal position. It's the most common position. And diffuse abdominal pain will also occur in early acute appendicitis. So appendicitis, it can occur anywhere, pain. So next is minimally invasive surgery in pregnancy. So what are the advantages of LAP? So patients with intrauterine pregnancy had no increased fetal loss or observed negative effect on long-term outcome. So first, what they thought was because of carbon dioxide pneumoperitoneum, there will be increased risk of fetal loss, but it was only equal to open. So major concerns of laparoscopy: injury to uterus, decreased uterine blood flow, fetal acidosis, preterm labor from increased intra-abdominal pressure. So these are the concerns of pneumoperitoneum due to laparoscopy. So technique, open technique and closed technique, they are saying we can use both for insufflation. So decreased uterine blood flow for pneumoperitoneum remains a theoretical concern. So it is only theoretical risk. Risk of pneumoperitoneum may also be less than the risk for direct uterine manipulation that occurs with laparotomy. So all the risks of pneumoperitoneum, it is less than the risk with open surgery. So fetal respiratory acidosis with subsequent fetal hypertension and tachycardia have been observed in pregnant models, but were reversed by maintaining maternal respiratory alkalosis. So the fetal respiratory acidosis, it was reversed by giving maternal respiratory alkalosis. So another is one SAGES criteria. So SAGES criteria, they did a big study. So they gave us some guidelines. So according to the plus signs, so if there is 1 plus, the quality of evidence is very low. 2 plus means low quality of evidence. 3 plus is moderate, and 4 plus is high quality evidence. And strength of recommendation is weak or strong. So if it is weak recommendation, it is not recommended. Strong recommendation is it is very much recommended. So about laparoscopy, so obstetric consultation is obtained. So whenever possible, operative intervention is deferred until the 2nd trimester, but laparoscopy can be safely performed during any trimester of pregnancy when the operation is indicated. So this is a very strong recommendation with high quality evidence. So what is the thing is that laparoscopy can be done in any trimester, and any operative intervention has to be deferred until the 2nd trimester. So next is pneumoperitoneum enhances lower extremity venous stasis already present in the gravid patient, and pregnancy induced a hypercoagulable state. Therefore, pneumatic compression. So the use of pneumatic compression in hypercoagulable state are used whenever possible and beyond the 1st trimester. So left lateral decubitus position and partial left lateral decubitus position to minimize compression of the vena cava. So this is strong recommendation with 2 plus. So it is not high quality evidence, only it is low quality evidence, but we have to use pneumatic compression because of strong recommendation. So next is fetal and uterine stasis, as well as maternal end-tidal CO2 and arterial blood gas levels needs to be monitored. So monitoring, it has strong recommendation with moderate quality evidence. Next, uterus needs to be protected with lead shield of intraoperative cholangiography and fluoroscopy. So it is a strong recommendation, but only low quality evidence is there for protecting the uterus with shield. So next, open versus closed. So initial abdomen access can be safely accomplished with the open Venous needle or optical trocar technique by the surgeon's experience. With these techniques, if the location is adjusted according to fundal height. So it is only weak recommendation. So we can use any technique. So pneumoperitoneum, carbon dioxide pressure of 10 to 15 millimeter mercury. So that is the point where we have to keep the pneumoperitoneum. So it is strong recommendation with 3+. So moderate quality evidence. So because of, so we'll see this tableau column. So advantages of laparoscopy: decrease fetal depression, secondary to decreased narcotic requirement, lower rates of wound infection, incisional hernia, diminished post-operative maternal hypoventilation, decreased manipulation of uterus, faster recovery with early return to normal function, decreased risk of ileus. So these are advantages. So what are disadvantages? Possible uterine injury, decreased uterine blood flow, preterm labor, increased risk of fetal acidosis, decreased visualization with the gravid uterus. So those are the disadvantages. So next, because of intra-abdominal domain is altered as the uterus grows, trocar placement should be altered from the standard configuration. So there is one image. So this is the image. So normal for a lap appendix, the circles are the normal position and the arrow marks are the altered position. So they can lie along any path of the arrow marks. Next is so Hassan technique and Veris needle technique, ultrasound guided trocar. So they are all there. Regardless of the technique, uterus should be manipulated little as possible. So inadvertent entry into the uterus. So when we do laparoscopy, if suppose the trocar goes into the uterus, what we should do? So we should just simply close the defect with absorbable suture, followed by monitoring and possible indomethacin tocolysis can be given to which is usually adequate to prevent preterm delivery. So we have to close the rent with absorbable suture and we should give tocolytics to prevent preterm labor. So that is the thing we should do if we enter the uterus during lab. So next, very important topic, we can expect questions: breast mass in pregnancy. So CA breast in pregnancy, which trimester, what to do, it is very important. So first, it has become increasingly more prominent as more women delay childbearing, usually in 30s and 40s. So the most common age group for breast cancer is around 30 to 40. So most of the modern day, because of the woman, they are delaying the pregnancy. We are getting a lot of breast cancer in pregnancy. So 1 in 3,000 pregnancies, that is the incidence. So mass is similar size and would be easily palpable in the non-pregnant state, but maybe obscure or palpable masses may be attributed to normal pregnancy-related changes. So breast density will be increased. So all those will cause delay in diagnosis. We can't palpate the mass easily. So benign breast lesions like galactosile, mastitis, abscess, lipoma, fibroadenoma, nodular hyperplasia, and lactational adenosis accounts for 80% of breast masses. So remaining 20% is only pregnancy. However, any palpable mass that persists for 4 weeks or longer. So this is important. 4 weeks or longer, if the mass is still there, we have to evaluate for pregnancy. So imaging and biopsy. So there's no different point in this. They're just saying we have to do core needle biopsy. So if we use appropriate shielding, mammography carries limited risk to the fetus. Mammography, but mammography, what is the problem is there is high false negative because of dense breast. So we can't pick up easily in mammography. So mammography is limited. Ultrasound is able to distinguish solid from cystic lesions in 97% cases. MRI, two main risks to the fetus are magnetic field and electromagnetic radiation causing heating and cavitation. So MRI is also dangerous. So core needle biopsy is the most appropriate method. So ultrasound is safe. Safest is ultrasound. If we can't pick up using ultrasound, we can use MRI. So most common non-gynecological malignancy in pregnancy is breast cancer. So it is more common in women with genetic predisposition. So usually breast cancer, most common is sporadic. But in case of pregnancy, more common in, it is the BRCA1 and BRCA2. So sorry, they're saying, they're not saying sporadic and familial. They're saying in the woman with genetic predisposition, more common is breast cancer. It will occur more commonly. They're saying like that. So ductal carcinoma is the most common pathological type. 75 to 90% of breast cancers in the pregnancy. So just like non-pregnant, ductal carcinoma is most common. So delay in diagnosis almost for 6 months occurs, but mean delay is 1 to 2 months. So what is the problem with delay? 1 month delay increases the risk of nodal mets by 0.9%. 6 months delay increases the risk by 5.1%. So that is the problem with the delay. So women with pregnancy associated breast cancer present with large primary tumors and high risk for positive axillary lymph nodes. So hyperestrogenic state may correlate with the rapid tumor proliferation and axillary lymph node mets, although pregnant women and non-pregnant women have the higher percentage of estrogen receptor negative cancers than older women. So ER negative cancers are more in the non-pregnant young woman and pregnant woman. So older women will have more ER/PR positive, but pregnant and non-pregnant young women will have more ER negative. So likely caused by down regulation of estrogen receptors during pregnancy. So gadolinium contrast. So we saw gadolinium contrast was safe, but it is a category C drug because gadolinium crosses the placenta and has been associated with fetal abnormality in rats, but human studies are not there. That's why it's category C. So MRI is not currently recommended for breast imaging in the pregnant patient. So only if USG cannot pick up, we have to do. Next is core needle biopsy. So major risk is hematoma formation and milk fistula. So there is one concept called milk fistula. They have given some points about milk fistula. So the risk for milk fistula can be reduced by stopping lactation for several days before biopsy and by emptying the breast of milk just before the procedure. So there is dense breast, most of it will be filled with milk. So we have to stop breastfeeding several days before biopsy, and we should fully milk out the breast, and then only we should do core needle biopsy. If the biopsy is done postpartum, a 1 week course of bromocriptine may be given before biopsy. So postpartum, we should give 1 week bromocriptine. So in order to antagonize the prolactin. So mainstay of therapy. So now coming to the very important topic, treatment of breast cancer in pregnancy. So mainstay is surgical resection, modified radical mastectomy. So it eliminates the need for adjuvant radiation. So first point is, so this they can ask us a scenario. So pregnant patient, CA breast, stage 1, stage 2 cancer, mastectomy with axillary dissection is preferred. So that's all. Stage 1, stage 2, that is enough. So sentinel lymph node biopsy, they don't know how much risky it is. So unknown risk to the fetus, and it is avoided. So there is no proper data. So they are avoiding sentinel lymph node. So stage 1, stage 2, only surgery, mastectomy with axillary dissection. So that is simply MRM. So next scenario, if it is diagnosed during the late second trimester or later, immediate breast conserving lumpectomy and axillary dissection followed by radiation postpartum. So late second trimester, then what the advantage is that we can give chemo. So we can do lumpectomy and axillary dissection followed by radiation postpartum. So what happens if it is diagnosed in first trimester or early second trimester? So what is this period? First trimester, early second trimester, which is a very important period for organogenesis. So if you diagnose breast cancer there, what we should do? We should do lumpectomy and axillary dissection followed by chemotherapy after the first trimester and radiotherapy after delivery. So these are the 3 important scenarios. So first scenario is early stage. Early stage, no need chemotherapy, anything. Only mastectomy, axillary dissection. Second scenario is if it is after the organogenesis, that is late second trimester onwards, we can do surgery and give radiation postpartum. But if it is diagnosed in first or early second trimester, we should do surgery and then we should give chemo in the second trimester, RT after delivery. So chemotherapy, what is the indication for chemotherapy? Node positive cases or node negative tumors with larger than 1 centimeter size. So size and node, if it is more than 1 centimeter, we should give chemo. If node is positive, we should give chemo. So anti-metabolites
what about a sentinel lymph node biopsy?
Sentinel lymph node biopsy, actually unknown risk to the fetus is there. So they're saying it is avoided until the safety of radioisotope has been determined. So they're saying there is not much data. So okay. that is only they are given here. So
and
next is anti-metabolites.
Radiotherapy. If you diagnose the patient during late second trimester.
Only postpartum. We should not give radiotherapy. Is absolute contraindication in pregnancy.
Okay, chemotherapy?
Chemotherapy second trimester.
Okay.
So chemotherapy second trimester, radiotherapy postpartum.
Okay.
So next is anti-metabolites. Anti-metabolites such as methotrexate are avoided because of high risk of spontaneous abortion. So we should avoid methotrexate. Other agents have been associated with congenital malformations and complications such as preterm delivery, low birth weight, hyaline membrane disease. So in one study, they have found out 5-fluorouracil, cyclophosphamide, and doxorubicin. None of the infants had congenital malformation, and but long-term effects are not known. So this CAF, cyclophosphamide, A is adriamycin or doxorubicin, and F 5-fluorouracil. CAF can be given, CAF regimen. So cyclophosphamide and doxorubicin can enter breast milk, and breastfeeding is contraindicated during chemotherapy. So chemotherapy we should give before breastfeeding itself. That is in second trimester we should start and we should complete. So radiation, induction of childhood malignancies, all those are there. So it is directly related to the dose. So directly proportional to the amount of dose given. And rapidly proliferating cells of the fetus are most sensitive to radiation therapy. And exposure greater than 1 gray during this period have high likelihood of causing fetal death. So what we saw earlier, total pregnancy, only 5 centigrade should be given. If 1 gray is given, it will cause death. And 50 gray, because the standard therapeutic dose is 50 gray, we should avoid in the pregnancy. So even with abdominal shielding, greater fetal exposure is caused by scatter. So radiation is not recommended during pregnancy. Elective termination of pregnancy to receive appropriate therapy without the risk of fetal malformation is no longer recommended. So they will confuse us with this option. They will give one option as elective termination of pregnancy. So it has been given clearly, it is no longer being recommended. No improvement in survival has been demonstrated. So they are not doing that. So this is the flow chart. Just this is a summary of what we saw now. So breast mass more than 4 weeks, we should evaluate breast ultrasound. If it is cystic, no problem. We just aspirate. And if atypia is there, or if there is a solid mass, we should do true cut biopsy. So in true cut biopsy, if it is benign, we can do follow-up after delivery. But if it is malignant, what we should do? We should do mammogram or bone scan or MRI. So after diagnosing, we have to check whether it is early stage or late stage. Early stage, stage 1, stage 2, first scenario, what we saw. We should do surgery, breast conserving surgery or mastectomy. So if it is in the late second or third trimester, we should give post-delivery radiation. If it is first or second early trimester, we have to give chemotherapy after first trimester. So advanced also same, we have to give chemotherapy in the second trimester. So for cystic lesion, USG should be repeated after 6 weeks. If fluid recurrence occurs, then we should again do evaluation. If there is recurrence after 6 weeks. So if there is no recurrence, follow up after delivery. So just like normal breast cyst. So next is hepatobiliary disease. So hepatobiliary disease. So what all can occur is examples of liver disorders are unique to pregnancy, like acute fatty liver of pregnancy, AFLP, intrahepatic cholestasis, preeclampsia or eclampsia, and HELP syndrome. So pre-existing liver disorders may manifest with complications during pregnancy, including hepatic adenoma and hepatocellular carcinoma. Hepatic adenoma can rupture and cause hemoperitoneuria like that. So next, first is we are going to see acute fatty liver of pregnancy. So acute fatty liver of pregnancy, the cause is unknown. Risk factors are common in first pregnancy, twin pregnancy, and women who are pregnant with male fetus. So this is 3 unusual, very confusing causes. So first pregnancy, twin pregnancy, male fetus. So these are the 3 risk factors. So although it has been diagnosed as early as 26 weeks, it usually occurs in the 3rd trimester, typically around 35 weeks. So most common time for AFLP is 3rd trimester. So AFLP carries 20% maternal and fetal mortality. So significant liver dysfunction within 2 weeks of onset. So that's why it is called acute. Within 2 weeks, there is liver failure. So next is, so what we should do? So there is no specific treatment for acute fatty liver of pregnancy. Prompt delivery after diagnosis may prevent progression to fulminant hepatic failure. So here we can do termination of pregnancy. If we do prompt delivery, most of the time it is in the 3rd trimester, so we can deliver the baby. If we deliver the baby, we can prevent the patient from developing fulminant hepatic failure. So surprisingly, magically, after delivery, the liver function will return to normal. So that is the AFLP. Next is HELP syndrome and other factors. So preeclampsia or eclampsia occurs in 10% of cases, and they have associated liver involvement ranging from severe elevation of hepatic enzymes to HELP syndrome to hepatic rupture. So all these can occur because of preeclampsia and eclampsia. So hepatic hemorrhage or rupture occurs primarily during third trimester and can develop up to 48 hours after delivery. So patient will be hemodynamically unstable for rupture. So diagnosis is suspected in pregnant lady with preeclampsia who develops right upper quadrant pain. So preeclampsia with sudden right upper quadrant pain, we should suspect hepatic rupture. So CT scan is highly specific. Ultrasound is usually non-specific. So another problem is hepatic hematomas without evidence of ongoing bleeding in hemodynamically stable patients can be managed non-operatively. So if the rupture is only limited to hematoma and patient is stable, we can manage non-operatively. So, and if there is, we have to do immediate intervention if there is hemodynamic instability. So maternal fetal mortality rate in hepatic hemorrhage is 60 to 80%. So very high mortality. Then immediate laparotomy with abdominal packing or hepatic artery ligation reduces the maternal and fetal mortality. So just like liver laceration, we should immediately open, keep pack, and we can ligate the hepatic artery if needed. Abdominal packing, if the patient is unstable, if the patient is relatively stable or abdominal packing has been unsuccessful in controlling hemorrhage, angiography with selective embolization can be performed. So that is one thing we can do. So next is hepatic adenomas. Hepatic adenomas are uncommon and they occur in association with glycogen storage disorder. So in liver chapter we saw it is glycogen storage disorder type 1A. So that is associated with hepatic adenoma. Diabetes, exogenous steroids, and pregnancy. So they're usually solitary lesions that have low potential for malignant transformation. So the problem here is not malignancy, it is rupture and the hemoperitoneum. So hereditary defect in carbohydrate mechanism. So that is glycogen storage disorder 1A that results in hepatocyte hyperplasia and adenoma formation. So hypothesis that elevated levels of endogenous hormones may contribute to hepatic adenoma formation, although no data have shown regression of hepatic adenoma after pregnancy. So AFLP, acute fatty liver of pregnancy, it will magically become normal after pregnancy, but hepatic adenoma, it will not regress after pregnancy. So major risk of hepatic adenoma during pregnancy is spontaneous rupture. So mortality we saw 60 to 80% for mother and fetus. Immediate laparotomy is needed with the cesarean. We should deliver the baby, immediate laparotomy, control of hemorrhage, and resection of adenoma if possible. So elective resection may be performed before the pregnancy. We can do elective resection or resection during second trimester. So second trimester is the window period. Any surgeries we should be doing in the second trimester. Next is subsequent pregnancy and oral contraceptive use should be discouraged in these patients if they are having hepatic adenoma. Next, cavernous hemangioma is the most common benign tumor of liver and it is found in 2% of autopsy patients. So benign tumor is most common is cavernous hemangioma. So just like normal liver, most common is hemangioma. So it is female predominance. Estrogen may be associated with the growth of liver hemangioma. So treated by steroids, radiation therapy, surgical resection, and recently embolization. So another thing is incidental intra-abdominal hemorrhage originating from liver hemangioma in 36 weeks twin pregnancy have been delivered by emergency, and so that's just a case report. So next to cholelithiasis. Cholelithiasis, cholecystectomy for symptomatic cholelithiasis is second to appendicectomy as the most common non-obstetric procedure. So first non-obstetric procedure is appendicectomy, second is cholecystectomy. So incidence 0.05 to 0.1% will be symptomatic. So elevated estradiol and estrone also increases lithogenicity. So that is the cause for this stone formation. Ultrasound is diagnostic. So this is important point. Historically, prior to laparoscopic technique, pregnancy patient with clear operative indications such as obstructive jaundice, gallstone pancreas, cholelithiasis underwent cholecystectomy regardless of gestation age. Patient with recurrent biliary colic or acute cholecystitis that responds to medical management are treated expectantly until delivery at the time and then underwent cholecystectomy. So before laparoscopy, they used to do only for the gallstone pancreas, cholelithiasis, obstructive jaundice, and they'll give medical management if it is manageable, and then only do cholecystectomy after pregnancy. But after laparoscopic approach, there is decreased risk for fetus, mother, and there is also decreased surgical risk. So for open cases, the hospital stay was 6 days. For lab case, it is only 3.2 days. And conversion rate is 3.8%. So it is a little bit high conversion rate, 3.8%. So next is there is decreased rate of spontaneous abortion and preterm labor after laparoscopic procedure because there is very less uterine manipulation and all by lab. So lab cholecystectomy for symptomatic biliary colic in the first or second trimester are not waiting for third trimester or postpartum. So they are saying we can also do in first trimester, but ideal is second trimester. So complications from non-operative management of gallstone disease results in increased maternal and fetal mortality. So gallstone pancreatitis, there is 15% fetal maternal and 60% fetal mortality. So that's why we have to do cholecystectomy if the patient is symptomatic, or else there will be more fetal mortality. So spontaneous abortion is 12% with open chole during first trimester, and 5% and 0% during second trimester. And risk for preterm labor is 0% during second trimester and 40% during third trimester. So all these data, they say second trimester is ideal. So here they are saying till now we saw open or closed, anything can be done, but here they are specifically mentioning open technique using Hassan's trocar is recommended. So intraoperative cholangiogram or endoscopic retrograde cholangiopancreatography is indicated for choledocholithiasis. Uterus needs to be protected with appropriate shield. 1 second. Okay. So shielding has to be done, and then we can do this intraoperative cholangiogram and all. So laparoscopic cholecystectomy can be safely performed during third trimester, although risk for preterm labor is increased. So preterm labor was successfully managed with tocolytics. So best is second trimester, but third trimester also we can do using tocolytics. So next, adrenal disease. Adrenal diseases, they are telling about pheochromocytoma, rule of 10, all those. So they can occur sporadic as a part of men syndrome. So important MCQ, pheochromocytoma will not occur in men 1, only in men 2 and men 3. Men 3 is men 2B or VHL. So postpartum maternal mortality is as high as 55%, with fetal mortality also exceeding 50% for pheochromocytoma. So treatment, with the treatment, maternal mortality has reduced to 0% and fetal mortality has reduced to 15%. So diagnosis, same, urinary catecholamines, all those. MIBG is not recommended because these are small molecules that may cross the placenta. So iodine 131 MIBG, meta-iodobenzyl benzyl guanine, that should not be done. So surgery, when should we do surgery? Surgical resection needs to be performed before 20 weeks of gestation, when spontaneous abortion is less likely and size of the gravid uterus does not interfere with the procedure. If the diagnosis is made late in second trimester or during third trimester, medical management followed by combined cesarean and resection of pheochromocytoma. So here also we are having two scenarios. So first scenario is diagnosed before 20 weeks, we can do surgery. If it is diagnosed late in the second trimester or third trimester, we should medically manage, give alpha blocker, beta blocker, and then during delivery, we have to do cesarean along with resection of the pheochromocytoma. So same only alpha blocker, calcium channel blocker, beta blocker, all those. So close monitoring. So beta blocker, it might cause IUGR, intrauterine growth retardation. So it should be monitored properly. So laparoscopy is safe for adrenalectomy. So next is thyroid. So thyroid, both the hyperthyroidism and hypothyroidism both can occur. So there is a recent guidelines. So first thing, what is the first step? So we'll get confused. They'll give options, TSH, ultrasound, or something else. We will rule out the other two options, but we'll get confused between TSH and ultrasound. So it is not ultrasound. First step for thyroid disease is TSH. So check TSH levels. Initial levothyroxine dosage is based on severity of symptoms. Levothyroxine is started as 2 micrograms per kg per day. If TSH is less than 10, then dose is adjusted to 1. That is 100 mics or 0.1 mg. So it should be adjusted to 100 mics. So monitor TSH levels every 3 to 4 weeks. So monthly we should monitor. So what is the goal TSH? Goal is it should be less than 2.5 milliunits per liter. So monitor serum TSH and total TSH every 4 weeks. That is every monthly. So next is hyperthyroidism. Hyperthyroidism, gestational thyrotoxicosis is usually self-limiting and spontaneously occurs by 20 weeks. So not much of treatment is needed for gestational thyrotoxicosis, but most of the cases of hyperthyroidism are due to Graves' disease. So after diagnosis, we have to give medical treatment with thioamides like propylthiouracil and methimazole is the mainstay of treatment. So propylthiouracil only, but here it is not given, I think. So first trimester, second trimester and all propylthiouracil, then afterwards we can give methimazole, carbimazole. So somewhere else I read. Okay, so subtotal thyroidectomy for Graves' disease is reserved only for, so what are the indications of subtotal thyroidectomy for Graves' disease in pregnant patients? So those who are taking high dose of propylthiouracil more than 600 mg per day, methimazole more than 40 mg per day, allergy to thioamides, and non-compliant or have compressive symptoms because of goiter size. So these are the indications. So two values are given. Propylthiouracil more than 600 mg is taken, methimazole more than 40 mg. Next is surgery is performed during the second trimester as usual, but before 24 weeks to minimize the risk of miscarriage. So even in second trimester, we should do it before 24 weeks. 2-week course of beta-adrenergic agent along with potassium iodide is implemented to reduce the size. So all those preoperative optimization should be done. Next, thyroid nodules have a higher prevalence during pregnancy. Thyroid cancer, if it is there, we have to do FNAC, ultrasound evaluation, and surgery is recommended during second trimester before 24 weeks. So this before 24 weeks is the cutoff. After second half of pregnancy, surgery can be performed after delivery. So post-operative radioactive iodine also needs to be delayed until after delivery. So next is small bowel disease. Small bowel disease is the third most common non-obstetric abdominal issue after acute appendicitis and cholecystitis. So first is appendix, second coli, third is small bowel. So usually occurs during the second and third trimester. Most common cause is adhesions. Other causes are volvulus intussusception, malignancy, hernia. So pain is present in 85 to 98%, colic in nature. So bowel distension may be marked but difficult to assess because most the gravid uterus will become will also be the cause for distension. So one more thing is plain X-ray. So plain X-ray diagnosis is made. So here we might get confused. We'll think X-ray is radiation and we might not mark the option. But for bowel obstruction, they are telling X-ray. X-ray is enough. Serial examinations with X-ray. So conservative management, NG tube, IV fluids, and but the thing is for operative management, the threshold should be less. For in non-pregnant, we will do laparotomy only after giving trial of non-operative for 48 to 72 hours. But here for 6 to 8 hours, if it does not improve, we should do laparotomy or laparoscopy. So the threshold for laparotomy should be lowered. So that is important difference. So midgut volvulus is the dreaded complication. Early exploration is warranted if diagnosis is unclear. So we should do surgery immediately and threshold should be less. So next is coming to appendicitis. Appendicitis is predominant during second trimester. Delay in diagnosis results in increased perforation rate of 10%. So there is high perforation rate. Fetal mortality increases 1.5% in acute appendicitis to 35% in perforated appendicitis. So very high mortality in perforated appendix. And preterm labor and preterm delivery occurs in 40% cases. Next, as the uterus enlarges, appendix is driven upwards. So in the counterclockwise rotation. So upwards and counterclockwise rotation. So that is important. Pain is in the right lower quadrant is the most common symptom regardless of gestation age. It can also be in the right upper quadrant. Suspected acute appendicitis, we should do emergency appendicectomy. So in non-pregnant patients, 10 to 15% negative laparotomy rate is considered acceptable because of the increasing rate of mother and fetus appendiceal perforation. Negative appendicectomy rate of 30 to 33% can be acceptable. So in non-pregnant, we should not have a negative appendicectomy. But if it is pregnant patient, even negative appendicectomy rate up to 33% is acceptable because it is very bad if it gets perforated. So it is better to operate. So even negative appendicectomy may be associated with increased risk of fetal loss, but still it is better to have a clear-cut diagnosis. So next is, it was concluded that improvement in fetal outcomes would result from improvement in diagnostic accuracy and reduction of the rate of negative appendicectomy. Positive ultrasound was considered to be diagnostic for appendicitis with MRI without gadolinium or CT being used to confirm or exclude the diagnosis in negative or not diagnostic. So it is first is ultrasound. If ultrasound cannot pick up, we have to do MRI without contrast. Even if MRI cannot be done, CT. Final is CT. So laparoscopy, that is only the modality of choice. So not much point. So there is no role for non-operative management of uncomplicated appendicitis in pregnancy because of higher rate of peritonitis, fetal demise, and shock, and venous thromboembolism also. So we should not wait. If the diagnosis is confirmed, we should operate in pregnant patient. We should not do conservative. So CT scan can be used when MRI is unavailable. Next, port placement. First entry is in the supraumbilical. So usually we do infraumbilical or umbilical port, but in pregnancy we should do supraumbilical. And before inserting the port, we should palpate for the fundal fundus of the uterus. And when we palpate, the port should be put 3 to 4 centimeters above. So colonic pseudo obstruction or Ogilvie syndrome. So Ogilvie syndrome also occurs in pregnancy. Neostigmine is effective in the first line therapy in non-pregnant. Its safety in pregnancy is unknown and can be safely used in the postpartum period. Colonoscopic decompression has been described in postpartum patients with laparotomy indicated only in suspected perforation. So neostigmine is the first line. It can be used in pregnancy, but its safety is not known. So vascular disease. What are vascular diseases? Ruptured splenic artery aneurysm can occur in pregnancy. So that's why when we see a splenic artery aneurysm, we should treat it. So they have given cutoff. Cutoff is 2 centimeters or larger. So if it is seen, then we should treat. Rupture occurs during the 3rd trimester. Most common time for splenic artery rupture is 3rd trimester. So maternal mortality is very high, 75%. Fetal mortality almost 100%. Multiparity increases the risk. Because of multiparity, the strength of the artery may get reduced. So rupture is a 2-stage process. First stage is it gets accumulated in lesser sac, and lesser sac will provide temporary tamponade. Second stage is it goes out of the lesser sac and it will cause hemodynamic instability. So 2 centimeters or larger, we should embolize the aneurysm. So next is iliofemoral venous thrombosis. So DVT. DVT is just like that we saw it in the hypercoagulable state, 6 times more common in pregnant patients. Thromboembolism. So number of factors included mechanical obstruction of venous drainage by enlarging uterus, decreased activity in late pregnancy, intimal injury from vascular distension or surgical manipulation during cesarean section, abnormal levels of clotting factors. So these are the risk factors. So protein S serves as a cofactor for activation of protein C, which has anticoagulant activity. Therefore, deficiency of protein S and protein C will lead to recurrent thromboembolism. So what is the management? So we already saw acute venous, what we should do, acute arterial, what we should do. So acute venous, it is mechanical. Acute arterial, we should give RTPA, recombinant trans TPA, plasminogen activator. So risk for pulmonary thromboembolism and manipulation of the clot during thrombectomy would have catastrophic effects on both patient and fetus. So while doing mechanical method, we might cause pulmonary embolism also. So right retroperitoneal approach or interruption of the inferior vena cava by passage of Fogarty catheter, all those can be tried. Most effective technique is filter placement. So we should keep IVC filter through the internal jugular vein or femoral vein using guide wire, followed by thrombectomy. So because of increased risk of pulmonary embolism, first we should place the filter and then only we should do thrombectomy for DVT. So cable filters have been successfully placed in all trimesters of pregnancy and left lateral decubital position. Unlike in non-pregnant patient, the cable filter in pregnant patient should be positioned in the suprarenal vena cava to reduce the risk of compression or erosion into the growing uterus or damage to the vena cava during contractions. So we should place it only above the renal vessels to avoid compression by the uterus. Suprarenal location additionally protects against thrombus generated in the dilated ovarian veins. So ovarian vein thrombus also, it will protect it from developing into pulmonary embolism. So hypothetic risk of renal injury is there. It is only hypothetical risk. So close follow-up and prompt filter removal when no longer needed. So in pregnant patients, we should promptly remove the filter once the DVT is treated. So next, trauma in pregnancy. Trauma is the leading non-obstetric cause of maternal mortality. High incidence of spontaneous abortion, preterm labor, feto-maternal hemorrhage, abruptio placenta, uterine rupture, all this will occur. So next is resuscitation of the fetus is accomplished by resuscitation of mother, because only then fetal blood supply will be restored. So same only airway breathing circulation. In late stages of pregnancy, as described earlier, the uterine compression will occur. So we should put the patient in the left lateral decubitation position. So tilted to the left. So maternal tachycardia, hypotension may be delayed until the patient loses almost 30% of the blood. So what is the problem is Only after patient is in stage 2 or stage 3 hemorrhagic shock, there will be tachycardia hypotension. So trauma patient, we should immediately resuscitate with the fluids if the patient is pregnant, because the signs will be masked. So measurement of fundal height provides rapid approximation of gestational age. At 20 weeks gestation, it is at the level of the umbilicus and approximately 1 centimeter per week of gestation. So 20 weeks at the umbilicus. After 20 weeks, for every week, 1 centimeter we should plot. So vaginal bleeding may indicate abruptio placenta, placenta previa, or preterm labor. So if cloudy white or greenish fluid is seen from the cervix or from the perineum, the presence of amniotic fluid is confirmed by nitrazine paper. So in which the pH and the pH change indicates whether it is this thing. So it will change from green to blue. So another test is there, Kleehauser-Burke test. So this test is to find out the this thing, RH positive, RH negative, whether there is any immunization. So if the RH negative mother is having RH positive baby, because of trauma, this test will tell whether the mother has got immunized by the positive. So there is one thing called ROGAM therapy. All RH negative trauma patients are considered for RH immunoglobulin ROGAM. So this will prevent the this thing baby from getting the immunologically those problems. So most common cause of fetal death after blunt injury is abruptio placenta. So what is the earliest sign of abruption? Deceleration of the fetal heart rate. So that is the earliest sign of abruptio placenta. So X-ray, CT scan, and operative intervention should be completed without hesitation. So in case of trauma setting, we should not hesitate to do CT also. So we can do CT because always the mother's life is more precious than the baby's life in case of trauma. So this is the image showing femur fracture and abruptio placenta, that white color fluid coming up. So next is penetrating trauma during pregnancy, 16 to 38%. Fetal injury occurs in up to 70% cases, and fetal death 40 to 70% of cases. So bullets will produce a transient shock wave and cavitation. So because of the kinetic energy, the cavitation will occur. So that will cause the damage. So the density of the tissue, such as thick density of the uterus during early pregnancy, may rapidly dissipate the lower the amount of kinetic energy from low velocity projectile. So if it is a low velocity projectile, the uterus will dissipate the energy because of the high density. So in gunshot, can you recall what is low velocity and what is high velocity? What is the speed cutoff? Anybody can tell?
No, sir. No, sir.
So it is 2500 meters per second. If it is less than that, it is low velocity. More than that is high velocity. So management is individualized surgical exploration. So for penetrating injury, we should locally explore the wound. So emergency cesarean may be indicated. So what are the indications for cesarean section in trauma? So it occurs, its indications are maternal arrest after 4 minutes of unsuccessful resuscitation. So mother has gone for arrest. 4 minutes we have done CPR, still there is no response. We should immediately do cesarean. Fetal compromise with a stable mother. If the fetus is of viable gestational age, obvious impending maternal death. So if the mother is stable but fetus is unstable, we have to do cesarean. If the mother is not stable, if the mother is going to die, then immediately we should do cesarean. Or when gravid uterus interferes with trauma-related surgical interventions. So they are doing any pelvic fracture fixation or some trauma-related this thing for increased blood loss in pelvis. If the gravid uterus is not allowing the surgical this thing, we have to do cesarean. Next, removing iotocaval compression and increasing cardiac output. So for that reason also we can do cesarean. So maternal fetal survival rate is as high as 72 to 45, 72% and 45% respectively. Okay, so this 75% chance of fetal survival has been reported when fetal heart rate tones were present and gestational age were at least 26 weeks. So even 26 weeks fetus, if it is being delivered, its survival is good. 75% chance of survival. So best chance for fetal survival with an infant, intact infant is when cesarean section occurs within 5 minutes of maternal death. 4 minutes of resuscitation followed by 1 minute cesarean. So that's what we earlier saw. If the mother has gone for arrest, 4 minutes only we should do CPR. If there is no response, if arrest is confirmed, within 1 minute we should do cesarean. So that is the 5 minutes rule. 4 minutes CPR, 1 minute cesarean. So control of hemorrhage. So most severe form is placenta percreta. So there is one thing called MAP, morbidly adherent placenta, where the blood vessels will penetrate, chorionic villi will go into the uterine wall. So placenta percreta, chorionic villi will penetrate the uterine wall and go into adjacent organs like bladder, rectum and all. So it is very severe form of placenta percreta. So surgical ligation, we can ligate hypogastric artery, uterine artery, and rapid hysterectomy can be done. But it is less useful in MAP involving the bladder. So bladder, if it involves, even if we ligate the vessels, it is no use. So temporary aortic cross clamping can be done. So next, Ribova. Ribova, they have given very detailed explanation of Ribova. So Ribova reduces blood loss, improves maternal outcome, decreases rate of hysterectomy compared to traditional techniques of uterine balloon tamponade and hypogastric uterine artery occlusion. So all these techniques, uterine balloon tamponade, hypogastric or uterine artery occlusion, comparing all these, Ribova has reduced the rate of hysterectomy. So Ribova catheter is particularly helpful when placental blood loss approaches 700 ml. So there's another thing called new ER Ribova catheter, new emergency room Ribova catheter. So it is, there is little to no fetal radiation exposure. So that is the advantage of the new ER Ribova. So no radiation exposure. So what are the external landmarks? Anatomical distance between the common femoral artery and anatomical landing zones described for Ribova in men and non-pregnant. So there are 3 zones, zone 1 and zone 3 only they're telling here. So the target distance for zone 1 is supraceliac Ribova placement, approximately 46 centimeters. Zone 3 is infrarenal aorta at 28 centimeters. So zone 1, supraceliac 46 centimeters. Zone 3 is infrarenal 28 centimeters. So confirm the catheter position with X-ray and it has to be done. So we have to limit the radiation exposure to fetus. So X-ray can be better than fluoroscopy in limiting the radiation exposure. The application of Ribova, we all know. A lot of sound is coming. Okay, so there is one thing called proximal hypertension because of aortic occlusion. Proximal hypertension resulting from aortic occlusion has led to acute heart failure, cerebral edema, respiratory failure. So these are the complications of Ribova. Because of proximal hypertension, distal organ ischemia during occlusion can lead to renal failure, bowel ischemia, and paralysis. So proximally, right, acute heart failure, cerebral edema, respiratory failure. Distally, bowel ischemia, paralysis, renal failure. All those will occur. Washout of toxic metabolites following balloon deflation, that can also cause rebound hypotension and cardiac collapse. So complications are more in zone 1 because zone 1 is more proximal occlusion, supraceliac. So that is zone 1 occlusion is more complicated than zone 3. So zone 3 occlusion complications are less. So in theory, the risk of arterial rupture may be increased due to smaller vessel size. So small vessel, if we do Ribova, there is more risk of vessel rupture. Access site complications also are there. So hypercoagulability of pregnancy may put women at higher risk of arterial thrombosis. So because of all this arterial manipulation, more risk of thrombosis is there. Frequent monitoring of distal pulse in ipsilateral extremity should be done for Ribova. So proximal blood pressure may increase to undesirable levels, increasing the risk of heart failure or stroke. So proximal heart failure, stroke, respiratory failure, everything will occur. So lack of pre-existing shock may improve ischemia tolerance. So if there is a lack of shock before doing the Ribova, those patients will have better outcome because they will tolerate the ischemia. Zone 1 occlusion is tolerated only for minutes. Zone 3 can be longer tolerated because zone 1 is more proximal, more complication. Only for minutes they can tolerate proximal. So robust collateral circulation that exists in gravid uterus, particularly in the case of MAP, morbidly adherent placenta, may lead to incomplete hemorrhage control, from proximal occlusion alone. Retrograde flow and venous hemorrhage may result in liters of additional blood loss. So Ribova, it will only address the arterial occlusion. For venous hemorrhage and collateral hemorrhage, it can't do anything. So that is another disadvantage of Ribova. So Ribova, there is 7 French catheter and 12 French catheter. So 7 French catheter, it has more better this thing. 12 French has more complication rate. So flushing the catheter has to be done. So heparin, whether it has to be added or not, it is controversial. So author's practice, what he is doing is 30 ml of 2% heparin. 2 units of heparin per 100 ml of crystalloids can be used for flushing intraarterially through the sheath, and another 30 ml through the central lumen of Ribova catheter every 10 minutes while monitoring thromboelastography. So heparin is being used for flushing. So sheet should be removed as soon as it is no longer required, ideally within 24 hours. So within 24 hours, the sheet should be removed. So that is about Ribova. Next, the intrauterine balloon tamponade. So most common cause of massive hemorrhage after delivery is uterine atony. So failure of uterus to get contracted. So what we will do is we will insert the balloon and we will cause tamponade effect. So Bakri balloon, B-A-K-R-I. Bakri balloon is the balloon which is used by the American College of Obstetrics and Gynecology. So others are Foley's catheter, Rouge balloon, condom catheter, Schenckstegen Blackmore tube, all those. So Bakri balloon has proven efficacy. So 57% after cesarean and 100% after vaginal delivery. So Bakri balloon, you remember that. So adjuncts for major hemorrhage, cell salvage system. So reusing the blood. So the canister must have a minimum of 500 ml of blood before cells are washed and returned. At most 50% of the washed blood volume to come back to the patient. So up to 500 ml of blood loss should be there. Then only we can wash the cells and reuse. So intermixing of fetal blood, amniotic fluid or bacteria with salvaged blood are contraindications to autologous transfusion. So if fetal blood is mixed, if the fetus is Rh positive and mother is Rh negative, that is a contraindication to usage of cell saver. And another thing is, its safe use of cell saver has been demonstrated in obstetric practice, particularly when no future pregnancy is planned. So because the mother will get sensitized to the Rh positive, future pregnancy will get complicated. So anti-D Immunoglobulin. So we saw that Rogam. Rogam is used to prevent isoimmunization and should be administered to any Rh negative mother. So Rh negative mother, we should give Rogam, and it is better to avoid future pregnancy. So there are 390 publications in which blood contamination with amniotic fluid has been washed and re-administered without complication. So damage control technique, packing, laparotomy and packing for intravascular coagulation, DIC, avoiding excessive manipulation of uterus when placing packs and temporary abdominal closure can reduce impact. So pregnancy after major surgery. So benign disease, there is no contraindication for pregnancy. Special circumstances include bariatric surgery and total colectomy with IPAA. So bariatric surgery, what they are saying. So improvement in fertility and pregnancy outcome after weight loss. Because bariatric surgery, there is weight loss, there is improvement in fertility. And decreased incidence of maternal complications. So delay in planned pregnancy for up to 2 years following bariatric surgery has to be done. So 2 years they have to wait. If they do bariatric surgery, fertility has improved. So they do not differ. Even if they do ROIGB or restrictive bypass like banding or sleeve gastrectomy, it's all the same. But main thing is vitamin and nutrition supplementation, iron, folic acid, everything. So IPA, ileal pouch channel anastomosis for Crohn's. So no difference in birth weight, duration of labor, complications, and unplanned cesarean section. So there is no difference. One more thing is vaginal delivery patients have significantly higher incidence of anterior sphincter defect and worse quality of life. So these patients, already the sphincter will be weak. So if vaginal delivery occurs, it will damage the sphincter more. So we should offer them cesarean.
சொல்லுவாங்கல்ல, it will not affect the infertility, but it affects the fecundity. The IPA. செகண்ட் சைல்ட் பர்த்தை வந்து அஃபெக்ட் பண்ணும், அப்படிதானே?
ஓகே. அதாவது அந்த மாதிரி ஸ்பெசிஃபிக்கா அதுல கொடுக்கல. மெயினா என்ன கொடுத்துருக்காங்கன்னா, அந்த ஸ்பிங்டர் ப்ராப்ளம் தான் இன்க்ரீஸ் ஆகும். மற்றபடி பர்த் வெயிட், காம்ப்ளிகேஷன் அதெல்லாம் வந்து எதுவும் டிஃபரன்ஸ் இல்லை அப்படின்னு கொடுத்துருக்காங்க.
ஓகே.
ஓகே.
எய்ம்ஸ்ல கூட கேட்டாங்களே 2 வாட்டி கேட்டிருக்காங்களே.
ஆமா ரிப்பீட் क्वेश्चन. ஓகே.
Okay.
சோ malignancy இது ஆல்ரெடி பார்த்த பாயிண்ட்ஸ் தான் வரும். breast cancerல cytotoxic chemo causes ovarian reserve depletion. Hormonal chemotherapy necessitates a delay in pregnancy resulting in potential infertility. So the hormonal therapy will cause infertility. Chemotherapy will deplete the ovarian reserve. So embryo cryopreservation can be done before starting chemo or endocrine therapy. Pregnancy is more likely to occur in patients with prolonged survival and no evidence of disease recurrence. So survival has been based on initial stage and not affected by hormonal receptor status. So ER/PR positive, that is not a thing. Main thing is stage of the disease. If it is early stage, it is better. So some recommend that women wait for 2 years. So 2 years is same for bariatric surgery and for malignancy, but it is controversial. So last point. For women with localized disease, early conception 6 months after completion of their treatment is unlikely to reduce survival. So for localized disease means even after 6 months they can plan pregnancy. Occurrence of preterm labor or miscarriage is similar in patients with previous diagnosis of breast cancer compared with those with no history of breast cancer. So preterm labor, miscarriage rate and all is same. So it's a very important chapter. A lot of questions have come.
ஆமா சார். அட்லீஸ்ட் 2-3 क्वेश्चन வந்துரும் சார்.
So, breast cancer is a very important topic.